My name is Damian Cabrera. I'm part of NMAC, formerly known as the National Minority AIDS Council. It's an organization that does HIV advocacy work at a national level, has been around for over 35 years. And we work particularly with those who are disproportionately impacted by HIV, particularly those of people of color. Again, good afternoon and welcome. And I wanted to thank the National Hispanic Medical Association for putting this webinar together. I also wanted to mention that NMAC, as well as the National Hispanic Medical Association, we are proud partners of CDC's Let's Stop HIV Together campaign. If you don't know about this campaign, it's a campaign that has really full and accessible information for providers, for community members, and it's contains information about stigma, treatment, prevention. The materials have visuals that really represent those who we are trying to reach, and also has information that goes straight to the point to get your answers, your questions answered. And another thing that I really like about this campaign is the services locator, where people can find services around them, whether it is for HIV treatment, PrEP, or STI testing. And in the end, the National Hispanic Medical Association will share clinical tools and resources with you all so that you can have them and share them with your peers. You can also ask for some of these materials to be shipped to your location. And for context, the National Hispanic Medical Association empowers Hispanic physicians to really lead the efforts to improve the health of Hispanic and other underserved populations. Again, thank you for the National Hispanic Medical Association for inviting me to moderate today's webinar. I come from Puerto Rico, where I did most of my advocacy work, mostly LGBTQ human rights work, and then that led me to public health, and then HIV particularly, and I have been with NMAC around 4.5 years doing national work, particularly with Black and Latino men. And I believe that the conversation that we're having today is important now more than ever, as we have seen how HIV continues to impact disproportionately communities of color, one of them being members of the Hispanic community. A few months ago, we heard of news from the Kaiser Family Foundation on challenges that Latino MSM encounter when seeking HIV services, emphasizing the need to do this work, to have these conversations, and also to continue to push for improving the conditions where Latino MSM either receive services or have access to information, meeting language justice, and representation. And actually, according to the CDC, Latinos, who make up to 19% of the US population, accounted for about 33% of new HIV infections. And to be honest, that is completely unacceptable, and we must find ways to sustain these conversations like we are doing here today, bring advocates, providers, and policymakers together to find ways to really address these disparities. And also the analysis that I was just mentioning also found that Latinos are experiencing a disproportionate number of new infection and diagnosis across the US, with higher rates in the Southeast. Advocacy is needed now more than ever, and that's why the National Hispanic Medical Association put this amazing panel today. So I'm happy to be joined by great colleagues who will be sharing both the knowledge in the field and also the epidemiological data, diving in deeper into how physicians can be a resource to their patients and not a barrier to receiving care. So today we are joined by our CDC Community Ambassador, Dylan Brooks, Director of HIV Prevention and Education at Compass LGBTQ Plus Community Center. Next up, I would like to introduce Babak Yaghmaei, the Deputy Director of the Office of Infectious Disease and HIV/AIDS policy, who focuses on Region 3, 4, and 5, those jurisdictions at HHS. And lastly, I would like to introduce Francisco Ruiz, who is at the Office of National AIDS Policy. He's the director at the Office of National AIDS Policy at the White House. But before, and again, thank you for putting this together, and thank you for the panelists for your time and expertise. And before we start, a couple of housekeeping rules. We want to make this as participatory as possible, so make sure that you put your questions in the Q&A box, but also keep your microphones muted so that we can have an organized conversation, but you can also use the raise hand feature to mute yourself and really join the conversation. And the recording and slides will be housed at nhmamd.org and will be also sent out after the webinar. And now I would like to open up the floor to Dylan Brooks, who will be sharing with us about the work, what paved their passion for advocating for patients seeking comprehensive HIV care in a way that really identifies resources, but also addresses barriers to care in Region 4. So take it away, Dylan.
Thank you so much. Hi, everyone. Good afternoon, good morning, wherever you are in the world at this time. So thank you so much for that intro, Damian. My name is Dylan Brooks. My pronouns are he, him, and his, and I have the honor of working at Compass, the LGBTQ plus community center for Palm Beach County, as our Director of HIV Prevention and Education. I'm an ambassador with the CDC's Let's Stop HIV Together initiative, as well as a registered clinical social work intern working on licensure. All that to say, I love my job. So unfortunately, I don't have beautiful slides like I usually do, so y'all will just have to look at me during this, but it'll be a beautiful little conversation. So I was invited today to talk a little bit more about like HIV in the South. So I currently live and work in Palm Beach County here in Florida, but I'm originally from rural Northeast Georgia. So I grew up on a farm, totally fun. It doesn't look like I did, but I did. And so talking about HIV, we know that in the Southeast, there's a large number of HIV infections. And then when you look at Florida, we are the #1 for new HIV infections, and how people of color are disproportionately affected within those numbers. So there's a large number of different reasons why HIV is higher in the South. One of the first ones is looking at the concept of poverty and unemployment, and how if you fall within that, like not necessarily accessing proper medical care or having the ability to get to a provider and things like that. And then followed quickly by lack of access. So if you look at the South, sure, there are a lot of people here, but there's also a lot of farmland and places where folks might not have the ability to easily access medical care and medical treatment. Oh, wow, my face just got real big. And then also looking at the lack of competent sexual education. So I wrote down a little story here because I remember the very first time that I went and got an HIV test and sitting there scared out of my mind. Keep in mind, I went to school in rural Northeast Georgia. Comprehensive sex ed is not a thing. It's more like from Mean Girls, like wear a condom or you will die situation, not like actually giving you real information. So when I went and got my first HIV test, they looked at me and were like, do you know how HIV is actually transmitted? And I was like, no, I just know that I'm afraid and things like that. And they provided all this beautiful education that I got nowhere in the public school system. So also being able to work in a place where we can pick up where the school system probably left off has been an amazing opportunity. If you look at folks who are getting linked to care, for example, whether that be linkage to PrEP or linkage to ART, so antiretroviral therapy, 6 out of the 7 counties in there are 7 counties across the country that have the largest number of folks who are not linked to care, and 6 of those are within the southeastern United States. And a lot of that also has to deal with rural living and being able to either truly meet people where they're at physically, or is it somebody is in a bus for an hour one way just to go for a rapid HIV test or go to get your PrEP. And then also due to a bunch of different factors, including lack of Medicaid expansion here in the South, we also have the lowest number for PrEP intake or uptake. And a lot of that has to do with education, lack of access, and the lack of Medicare expansion. And then we flip the script a little bit and start looking at the opioid crisis. So the opioid crisis we know has really affected a lot of people across the United States. And then like when we look at HIV and Hep C infection rates, we also need to start looking at things from a harm reduction model. So at Compass, we have the ability to work with an organization called Rebel Recovery, which is the second legal needle exchange program here in the state of Florida, syringe exchange rather. And it has been amazing to watch participants come into Compass, come to Rebel, who probably never even access any type of harm reduction services to begin with. And they're getting their first HIV test. They're getting clean syringes. They're getting Narcan because you still have to buy Narcan sometimes. So we're like, why don't we just give this out for free the way that we give out condoms for free? And that's been an amazing success. And we just recently celebrated International Overdose Awareness Day. And I can't remember the number off the top of my head, but over 200 overdoses were avoided last year due to harm reduction material and folks having Narcan. So we know that the harm reduction model works. So I say all this to be like, how do you make your space a little bit more inviting and welcoming for the community? So I love the concept of from the front door to finance, and that's being sure that the entire organization is not only meeting your mission, but meeting people and being very opening and welcoming. So the first thing I want to bring up is the acknowledgement of pronouns. I'm always entertained when I get pushback being like, oh, we don't use pronouns. And I was like, I'm sure you do somewhere down the road, and it's okay. And it's okay to acknowledge your own pronouns. And I like the concept of mirroring. So how I did my introduction a little bit ago. Hi, my name is Dylan. My pronouns are, what's your name and what are your pronouns? It's as simple as that. Then being sure you have culturally competent staff. We work in very unique and very different settings all across the country. So being sure that you have folks who know what's going on the ground and also how to talk to people. Like not everything needs to be medical jargon 100% of the time. Like you can get down on the ground level and have true meaningful conversations that are not medically, like a lot of medical terms, basically. Also having stigma, reducing signage around your building and being sure that you have signage that reflects your population and what you folks that you're working with. So I was thinking back to a sign that I saw somewhere, and it was almost like they did this just to check it off somewhere. It was like a rainbow on something. And then I go and talk to the organization. I was like, do you have LGBTQ folks who work here? Do you know how the LGBTQ plus community works? So just slapping a rainbow on something does not mean that you're culturally competent or that you are all encompassing and welcoming of the LGBTQ plus community. Put policy into place, put practice into place, and make that all around amazing. One of the last things is having an effective collaboration. Effective collaborations are amazing if they're done effectively, and being sure that you're partnering with the right people at the right time. So for me, for example, in the prevention department, We probably won't partner with the animal shelter because the animal shelter doesn't need our services right now, but partnering with a local bodega and being sure that they have free condoms and free testing, that's more aligned with the mission than the animal shelter. And I say all of this from the front door to finance to look at the concept of the importance of affirming healthcare. So by being more affirming and knowing your clients and knowing your patients, we're able to have more honest conversations about not only the perceived, but also the realistic risk associated with HIV and other STIs. I had a conversation with a friend of mine a while back who sent me, it was something so obscure. She's like, this client doesn't think that they can get a STD because, and keep in mind, this is the South, they could do something with Coca-Cola. And I was like, that makes no sense. That's not medically accurate at all. But that also goes to show you how the perceived risk versus the realistic risk are at play here. So educating folks, being sure that they're getting the right amount of knowledge about HIV and STI prevention, as well as pregnancy prevention, if that's something that they so choose. And then also knowing that early detection and treatment are key for a healthy, happy life. And so getting tested at least every 3 months if you're going to be sexually active. And the treatment part, so getting initiated into treatment, and really everyone can play a part in ending HIV, and it really starts with getting tested and knowing your status. And I just want to end on this one note that I heard from a virologist in Nigeria associated with Mpox. And they said, when you neglect the disease anywhere, it spreads everywhere. So being sure that we are working on all fronts to end HIV and STIs and be culturally confident of our LGBTQ plus community. And I think that's it. I think I'm at time. Or maybe I went over. Thank you so much.
Good day, everyone. I think this is the part where I kick in with some slides. How you doing? My name is Babak Yaghmaei. I'm from the Office of Infectious Disease, HIV/AIDS Policy. So if you hear us say OIDP, we love acronyms, and that's where that acronym comes from. So just to give you a little idea of what our office is, as we go to the next slide, our office is about basically being a policy shop. What that means is we don't give out grants necessarily, but we work with every one of our partners, internal and external, across the HHS platform. And that's the idea, is to provide strategic leadership and management. What does that mean? Well, it means that anywhere we can be to understand and positively impact reducing the burden of infectious diseases from the federal side, we're going to be there. We're going to have our ears to the community. We have engagement teams for that. We work with 4 federal advisory committees, and one of them is the Presidential Advisory Council on HIV/AIDS, commonly known as PACHA. We deal with a range of initiatives, and also work with federal and non-federal partners to inform and make sure our national strategic plans make sense. For example, the STI National Strategic Plan is one example of those. But we won't spend too much time on the office, because if you have questions, you can reach out to me, because we're here to talk about the South and Southeast, synonyms there a little bit. But we know, as we go to the next slide, that HIV is being heavily impacted in the South, and we always hear disease burden is high in the Southeast. Well, one of those initiatives that I mentioned that HHS has and our office is heavily involved with is ending the HIV epidemic, and it comes with 4 pillars. Think of it this way: diagnose early, treat effectively, prevent often, respond quickly. And that's the idea and the goal behind the EHE. We do have jurisdictions, and there's a heavy presence of these jurisdictions within the Southeast. So it is not lost on us that this initiative alone will not be the only initiative or angle to do it. We have to think about it from a syndemic approach in addition to the EHE pillars. So as we go to the next slide, with just a little bit of level setting here, the definition of syndemics, it's just when two or more health conditions cluster and interact within a population. So, you got structural factors, social determinants of health come into play. We're talking about disease burden, and how we impact these is by having those drivers to be with us and enable us to do this in a syndemic approach, meaning that we can't just look at it from one silo. We have to look at it across and be able to have a more robust approach. And as we go to the next slide, this is the little bit of an insight into how the federal side of it looks. When we go in this slide, we talk about the syndemic approach. So the syndemic approach is just really making sure on the federal side, we're across all of our STI, HIV, viral hepatitis, substance abuse, mental health, just all over. As mentioned before by Dylan, we have to make sure the right players are at the table. So whether that's including non-traditional partners, making sure lived experience is part of it. So when we talk about people, place, science, and action, these are some of those items. And we can't forget about qualitative data. We can't just look at quantitative. I will share with you some quantitative data, though, which is part of this idea of how does the federal side of everything coordinate and communicate this. We also want to make sure that we're making data available. And when we think about data, as we go to the next slide, I wanted to start off by showing HIV incidence when it comes to Region 4. By the way, Region 4 is just the HHS designation of what the Southeast is defined, those states that make up the Region 4. So you got Florida, Georgia, Mississippi, Alabama, Tennessee, both of the Carolinas, North and South, and Kentucky. When you look at this, just visually looking at it, you can see the gap. The lighter blue line is the United States. Over these years represented here from 2017 for HIV incidence rate per 100,000, you can see the gaps right there. So just from a statistical purpose, in 2022, for example, 11.3 per 100,000 persons in the United States HIV incidence rate, whereas Region 4 was at 15.5 per 100,000. So as we go into another layer of HIV data in the next slide, you'll see that here we've broken it out for Region 4 and also states of Region 4 with the data of individuals who identify as Hispanic and Latino. And just looking at this, I mean, the idea is obviously to be visual, but it's also statistical, right? So when you look at this, Dylan already mentioned it. Florida is right there. You can see them at the top of this. These two graphs, whether it's just the region in totality, kind of mountaintop view, or as we look at the individuals who identify as Hispanic and Latino, there's quite a bit of gap. But also pay attention to how the numbers don't change too much, almost like some states are having what you would call a flat line. So as much as you might look at maybe Florida sitting up top in these high rates, or counts, excuse me, look at the states that haven't budged much. So there's impact to be made. Nothing is impossible, or else none of us would be here talking about it. So while the data does look a little like, oh my God, we got some homework, it's not impossible. It's not insurmountable. We just have to look at things a little different. And as we go into the next slide, one of those aspects we should really highlight, and this is kind of where I wanted to spend a little impact on this, is the linkage to care. And we talk about syndemics, but linkage to care. If the individual, you can look at this, I know that the one on the right looks a little like, oh my God, where are all these lines going? But just think of it this way. That's the issue, is the linkage to care does not continuously look like this clean line. It is all over the place. Yes, we can put an asterisk on 2020 because of COVID, but that's not the point here. The point is that linkage to care, we got some homework to do here. We can't talk about retention and care if they're not in care. So it starts right there, and that's where a lot of these advocacy efforts we talk about, and communication and coordination, all these things, they really are going to have at its heartbeat the linkage to care part, meeting them where they're at. What do they need? The syndemic approach, and then also linkage to care is not just going to be addressing HIV in some cases. It's going to be addressing a lot of the access to healthcare that those individuals are not getting. As we go to the next slide, just to give you an idea, when we talk about syndemics, we've got a national epidemic of syphilis. This is an overlay of HIV incidence rate and our syphilis rates when it comes to primary and secondary. By the way, shout out to our Kat Kim, our data and our data guru who helped us with this data, as well as a lot of our other team on the syphilis task force at OIDP, from Director Kay Hayes down, to get us this visual representation. If you break this down into 4 quadrants, the upper right quadrants, you can see as HIV incidence goes up, so does syphilis, primary and secondary, which, as we know, will also lead to congenital syphilis. And to give you a little bit of idea what we mean by the national epidemic of syphilis over the years, as we go to the next slide, just let this sink in as the colors get darker. And that kind of hits home when you think about primary and secondary syphilis. Getting us to 2022, 2023 data is not far behind. And as we go to the next slide, we talk about congenital syphilis, another overlay slide. This is when we talk about female, the dark black line going up is female primary and secondary syphilis rate, and then the blue bars are congenital syphilis. That is a lot of cases, and it is just going up. So HIV, syphilis. Let's go to the next slide and talk about equity. We talk about an equity approach. If you look at the left side, the percent of live births, when you see the green, which is Hispanic, Latino individuals who identify of Hispanic and Latino, and you look at the right, it's disproportionate. I mean, just look at any one of the priority populations that we talk about. So just to give you an idea of what the landscape is, we go to the next slide. We talk about our syphilis task force from the federal side. It is an internal federal task force. And as we move to the next slide, it's just giving you a just an idea of what the feds are doing on the federal side of making sure we have community input. We have 6 subcommittees. It is a federal task force. Health equity is key in this. So it does not let go of HIV or anything else. It is all encompassing to make sure that we are addressing those, and we learn lessons from that, and we have made some impacts. As we go to the next slide, we talk about the successes to date. We talk about the import of medicines, bicillin, extensilin, most recently lenticillin. We talk about policy flexibilities, funding flexibilities where it's needed. We already were doing that on the HIV side. Now we're doing it on the syndemic side. And now it's becoming all in one because we need to approach it that way and make sure that the community is being heard. And as we go to the next slide, it just talks about the critical importance of having an established partnership with provider organizations. So those of you that are providers here talking about seeing patients or addressing the HIV epidemic, you're also addressing a syndemic approach, or else it's not going to make a dent and we're still going to have those flat lines. So we've been able to get some task force has been able to just highlight some doxy-PEP guidelines, being able to get point of care testing considerations. As we go to the next slide, we put out some syphilis webinars for provider education. That's very critical when we think about syndemics. And you'll see this on the next slide when we see the talking about stopping syphilis, had a lot of provider education. And, you know, we've even had to policymakers had to be educated about this because we had to tell them, oh yeah, no, syphilis is still a thing. And provider education had to come into play a lot in addition to all the other multiple factors. So as we go to the next slide, and we just talk about some resources. Again, shout out to our team in OIDP for helping us with some of this information that you're seeing today. These are some of our resources. Anything we've presented to you today is available on the AHEAD. So it's AHEAD, as well as the CDC Atlas and different CDC databases for any information you want to see. I'll put the links in the chat during this webinar. And as we go to the next slide, I just want to say thank you for allowing this platform for the Office of Assistant Secretary for Health to be part of this nice panel, but also to the individuals who are here and taking time out. There's a reason we're all here, and it's to impact positively to the communities being impacted. So from the federal, from the non-federal, from the human side. It's not a lot of lost on us what you are doing and what still needs to be done. And if you need to reach out to me, please don't hesitate. And thank you again.
Thank you so much. I'm really interested in the systemic approach that you discussed. So hopefully in the Q&A we can discuss, have a discussion around that. And now I will pass it over to Francisco. Take it away, Francisco.
Hello, everyone. Can you guys hear me okay?
Yes,
Yeah,
we can.
perfect. Just want to thank NHMA for inviting me and for my panelists to sort of who are a tough crowd to follow. And just want to acknowledge the fact that as a cisgender, light-skinned Latino, I know that the panel doesn't necessarily represent all of our communities. I just want to sort of put that in the room, in the space, to say that we have Black Latinos, we have cisgender, transgender Latinas in our family and in this work. And so I just want to sort of uplift all those sort of folks who are doing the great work that may not be represented visually on the panel, but I know are doing the work on the ground. So I just want to sort of bring that into the room for today's discussion. And I'm really curious to have our Q&A. I also don't have slides. And I'm nervous, like Dylan, my space is going to get really big, so I'm going to keep moving back as it gets bigger. But I just want to say that, oh, there it is. I just want to say that I'm really honored to be sort of working within the White House, representing the great work of the administration, but also more importantly, of the community that's being impacted. As we know, it's really important to sort of lean into our expertise and our skills and our knowledge and our alphabets behind our name, but more importantly, our lived experiences. And as I recently heard in a meeting that I was at, really looking at our lived experiences as our lived solutions and how do we sort of move forward the epidemic and this work. We've had a lot of progress. So I'm really committed and excited to be doing this work alongside many of you. I'm not going to go into details of the National HIV strategy. As you know, we are sort of entering the end of the current version of the strategy. So right now, the current strategy takes us to 2025, which is next year, which in my life is like tomorrow. So right now, what we're doing is sort of taking note, having listening sessions, listening to community of what is working, what isn't working, and how can we sort of make sure we make some progress as it relates to the epidemic, and really looking at where are the gaps, what do we need to sort of prioritize, because we know we can't do everything, and how do we sort of prioritize our communities in the work that we know that has the potential to sort of end the epidemic. And when we say end the epidemic, we're not erasing any individual or any person living with HIV. We're talking about ending new HIV cases. We're talking about ending health disparities or in access to affordable HIV treatment. We're talking about ending stigma and discrimination. And so that's sort of when we talk about ending the HIV epidemic, that's what we're sort of centering on. We're still uplifting and making sure that people that are living with HIV still have access to medicine when we no longer have new HIV cases. So I just want to sort of bring that into the room as well. And so this is my 5th month into in the big brown house that I call home night and day. And in these 5 months, I've been able to sort of have really great conversations with community members, with federal colleagues, as well as private sector and other national organizations doing the work and or interested in doing the work. And in those conversations, I've been able to sort of hear from community, again, what's working, what's not working, what can we be doing differently, how do we sort of scale up, how do we innovate. And so I've organized some of the office activities under sort of 3 buckets. And so I just want to kind of share those quickly with everyone. And hopefully some of you have heard this before. And so this hopefully is a reminder. And maybe folks have heard it for the first time. So I welcome some questions and pushbacks in terms of where we are with some of these activities. And so one of them is really centering the science. And so how do we modernize our policies and base them on science, not on fear? And so some of those activities, we've seen some progress recently over the past couple of years with FDA in terms of the blood donation. We also saw the U.S. Public Health Services Commission Corps change their medical standards to accept people with HIV and chronic hepatitis B, knowing in the past these conditions were medically disqualifying. So we've had some progress, but we know that we're not where we need to be. And so some additional areas that the administration is committed to ensuring our policies are grounded in the latest science is around employment policies, making sure we conduct an assessment across the federal government to sort of update some of these outdated policies related to employment eligibility for people with HIV. We're also looking at organ transplant and clinical trial guidelines and making sure that people with HIV have access to the latest and greatest science. And so making sure we're equitable in terms of access to that. Also looking at health education curricula, making sure our young folks are receiving accurate and non-discriminatory information about their health and well-being, working with the Department of Education and others. And we know that sort of has layers because a lot of those decisions are at the local level. And then the other one that is also very sort of layered is HIV criminalization. We know that fear and stigma does not end the epidemic. It does not promote public health. And so working with our partners to assess and modernize laws that criminalize HIV status, ensuring they're based, again, on current scientific knowledge and do not perpetuate stigma or injustices. The other sort of bucket of the work is really accelerating our progress in our HIV response. And so I think we've had some momentum. I'm not going to go into sort of the numbers, but we've seen some progress. And so how do we sort of scale that up? How do we put a little espresso shot in that and sort of make it go faster? And what do we need to do differently in that work? And so some of that is coordinating across the federal government, strengthening those collaborations by supporting sort of data synchronization, co-hosting activities together to sort of maximize the knowledge sharing, looking at our technical assistance resources and trainings. How can we sort of lean into each other and do some cross-pollination of these great resources that are being developed at CDC, at HRSA, et cetera. And then also exploring funding efficiencies, looking at braiding funds as a sort of model and see how folks are doing that at the local level and how can we sort of elevate that at the federal level. The other sort of acceleration that I want to focus in on really is viral suppression, making sure that people with HIV have access, that we expand access to antiretroviral therapy and comprehensive support services. We've talked a lot about syndemics approach. So, I think we talk about a lot of these fancy words in public health. So syndemics really, if you think about it, is just two words: synergy and epidemic, and syndemics. And so how these health conditions sort of amplify and intersect, and our response also has to amplify and intersect and work together. And so breaking down some of these silos around the HIV funding and organizations with our substance use organizations and funding and our mental health services. How do we connect those dots? And particularly in the South, we know there's a lot of sort of deserts, and if you will, of services. And so how do we sort of connect the dots with those who are doing some of these other issues and lean into that? Also, in this area of acceleration is the translational research. We know there's a lot of great research happening. How do we foster collaboration across federal entities to translate innovation research into programs nationwide? And so how do we what's the pipeline look like from research to practice? And then lastly, in this sort of bucket is the congressional champions. We know we've had historically a lot of support in this work, but we also know currently we're having some challenges on the Hill. And so what I'm trying to do in my office is have these educational meetings with elected officials on the Hill, continue to lay the groundwork for additional congressional champions on HIV, and how do we bring in that next generation of congressional leaders to help support some of the great work that many of you are doing on the ground. And then the third sort of bucket or area that I really have been prioritizing is really sort of unapologetically looking at how do we lean into equity? What does equity actually look like? And so equity from HIV and aging, making sure folks who are aging with HIV continue to receive the services they need. Looking at existing programs and assessing some gaps in services for people aging with HIV. Looking at PrEP, again, we talked about viral suppression and the importance of getting folks who are living with HIV access to medication, but also make sure folks who are HIV negative that they have information around PrEP, and making sure that we collaborate across federal agencies to increase PrEP accessibility and affordability. And that means working with CDC and their recent pilot program that they announced, as well as CMS, who's doing coverage around PrEP and under Medicare, some changes there. And then also the pipeline, looking at the workforce. And so recently at the White House, we had a convening where we brought in 54 young Black, brown, queer leaders around the country from different sectors of the work, from legal sector, from the medical sector, from the nonprofit sector, from the private sector, to learn into and sort of really pass the mic, and how do we sustain and support these young people and sort of pass the mic to them as they sort of take us to the end of the HIV epidemic. And so really empowering the next generation. At the same time, how do we support existing workforce? A lot of our workforce has been tasked with sort of COVID when that was sort of starting and still with us. And then MPOX came around. At the same time, we're saying, hey, but this syndemics thing, you also need to sort of manage HIV and include STI. And so how do we support our existing workforce and really provide incentives for them to sort of stay in it and for the long haul, and also bring in new folks into the mix. And then lastly, the non-traditional partner engagement. I think a lot of times we forget that there's other great partners happening around us that maybe are not doing HIV. How do we bring them into the mix, really to elevate the involvement of these non-traditional partners, to leverage their influence, their expertise, their platforms for HIV education and service delivery. We need to sort of get out of the HIV bubble, if you will, and really bring HIV to different spaces. As if we're trying to get new people on PrEP, we need to make sure that we're going to them. If we want to get people diagnosed and into care, we need to go to new places and sort of make sure we find those individuals who maybe don't know their HIV status. And so that's a lot of the work that we're doing. And I'll just close with the National HIV strategies I mentioned. We're going to be doing a listening session next week at USCHA on Friday. I know it's going to be a tough sell, but it's at 6:30 on Friday in New Orleans. But we invite you to join us and then go have fun afterwards. But we're also going to be doing some other virtual sessions. We're going to try to do one also in Spanish, making sure that folks who are Spanish dominant to be able to provide their expertise and their thoughts around the National HIV strategy. And we're also going to be having an online way to put information and feedback online through a federal register. And so that's hopefully going to go live in the next few days. And so we'll make sure, hopefully through NHMA and other colleagues, to disseminate the information. The folks who are on the call today are able to sort of provide us the feedback. And once it goes live, it will be available for 60 days. And you're gonna not only be able to provide feedback on the National HIV strategy, but we're also gonna be in collaboration with HHS, having a feedback on the STI strategy that also sort of expires on 2025, as well as the hepatitis plan, as well as the vaccine plan. And so we're trying to, again, in spirit of syndemics, bring in all these sort of strategies and documents so they speak similar languages, we have similar sort of measures of success, et cetera. So I'll stop there. I think the caffeine is kicking through, so I'll let you guys take it from there.
Thank you so much, Francisco, for providing us with really an overview of the work that you're doing from the White House. Really, really exciting work. Now we are going to jump into the Q&A session. As a reminder for folks, you can use the webinar, the Q&A box, the chat, or you can raise your hand and we will unmute you so you can join the conversation. Before we have about 10 minutes for Q&A, and I think that one of the things that Francisco was mentioning that really resonated with me, one of the things was about diversity. And if there is something that we know in HIV, in the HIV field, is that there is no cookie cutter, or there is no one size fits all. When we're talking about the South, we are also talking about diversity of demographics in terms of race, ethnicity, sexual orientation, gender expression. So I really wanted to ask the panel how public health initiatives can be tailored to meet those needs that come from different backgrounds. And also thinking about, kind of the commonalities between the demographics, because there's always some middle ground and some, shared experiences, to put them put it somehow. But yeah, I would really like to hear what are your thoughts on strategies to acknowledge that diversity, but also to really lead into the difference and commonalities.
I can just share some thoughts from the federal side when we talk about looking at us internally is when we put out these federal programs, how are we looking at it? Just because it's been done a certain way for so long doesn't mean it needs to continue being done that way. So looking at it in a progressive manner means looking at it in the sense that when we put out notice of funding opportunities, we call these NOFOs, or when we have programs that are being flexible, are they being flexible in terms of incorporating those with lived experience? So when we talk about the HIV side of these programs, but when we look at it from a syndemic level, it's the equity lens, right? It's that old, it's an example I've seen before where just because everybody has a bike, which is equality, doesn't mean the bike fits everyone, which is equity, right? So when we look at these pieces of information that we have at the federal level, how are we looking at these funding opportunities to be dynamic as the landscape is? Yes, we realize some things are needed to be looked at creative. So how do we do that? And not just continuing the same circle. And having worked in some of these grant programs, I know myself from the HIV/AIDS Bureau and the Bureau of Primary Healthcare on the HRSA side, having the privilege to work with those programs, we know the potential's there. It's on us on the internal side to look at it. But to Francisco's point about listening sessions, what does that mean? It means listening, but then doing something with it, right? And you can hear that from all of us talking here. It's great to listen. It's great to get the feedback here, but we want to do something with that. So even us in the engagement teams, we need to make sure that the parameters we put into these grant programs are held to those standards that match modern times. And that could be from supportive services all the way to better incorporation of planning councils. And these are just myriad of examples.
Any additional thoughts, Francisco, Gina?
I kind of like how Francisco started with like acknowledging identity, and like we also have to like look at our own identity when we're looking at programs, depending on where you're doing these programs, things of that nature. So like me, for example, a white cisgender gay male who does his nails, all that good stuff, but also knowing that like I am not the expert in African American women, for example. So being sure that we're reaching out to those communities to see what is the appropriate lexicon to be working with, what is the proper way to say something, things of that nature, like really getting that community feedback.
I ditto to everyone said. I think we oftentimes, when we talk about HIV, we really sort of focus in on like the pill, the shot, the test, and I think that's obviously really, really important. But we also need to talk about, HIV prevention is employment, right? And so bringing in the workforce is really, really key, and that's something that's been a passion of mine for a very long time. Making sure that when we go to these conferences, we go to these meetings, that we're bringing in that sort of up and coming staffer that we have, and that might mean that you have to go to less conferences, but you're giving that opportunity for the other staffer to join, to sort of sit in a room, even if they're just taking notes. And so if we're really talking about sort of diversity in workforce, making sure that we have, it's going to involve us shuffling our budgets a little bit more. It's going to mean that we have to break down these acronyms because the folks are not all going to understand. And that's what equity is. It's about language justice, making sure that we have spaces like this that are simultaneously translated or, have captions, et cetera. And so I think our diversity is really, really important in the work. And again, it's not easy, right? But this work has never been easy, and it just means intentionality. But I think also, right now I don't have a team, but when I did have a team, I made sure it was important to, if I was being tasked to sort of engage Black sororities, for example, I'm not the one, obviously I care about the community and I care about the issues, and I am going to do everything I can behind the scenes, but the messenger is as important as the message. And so making sure that I would always try to make sure my staff who are competent, not only as a Black woman, but also the knowledge and skills, making sure that they had the chance to go to those meetings and truly sort of be the messenger and represent at that time CDC. And so I think we need to do that a little bit more. I think a lot of times we sort of get comfortable in going to doing the talks ourselves, and folks who are in sort of positions of power and privilege. So I think in terms of diversity, it's really important to sort of break that mold and getting folks who might stumble a little bit, but they're going to do it, right? And it's going to resonate differently than if I were to go to a meeting or Dylan or you, Damian, if it's not sort of the community that we're serving or representing. At the same time, there's a lot of importance about solidarity work, right? I think it's also important that I go to spaces that are focused on Black communities because I care about that issue and about the community as well. So there's a tension there around a diversity of making sure that we have the right messengers, but also being there in support and solidarity. And so there's a lot of sort of progress in that space, particularly in HIV, that it's not about fighting for crumbs, but it's about how do we make more pies, and how do we make sure that everyone has enough to do the great work to end the epidemic.
And I think you mentioned a key word, that is solidarity, that is ultimately the key to ending the HIV epidemic. And Babak, you were mentioning, and also Francisco, you were mentioning about the syndemic approach, right? And I think that that is key to not only ending HIV, but also being able to address other STIs. And thinking about, for example, Spanish monolingual folks that already have some barriers to get HIV tested. And how do we think about ways to, now that you're going to get HIV tested, let's also discuss about other STIs. That to say that I think that as we move forward, that has to be the approach that is holistic, that is inclusive. And I would like to hear from you how what policy changes, or how does that concept of syndemic approach can go from the federal level to organizations like Dylan's, or to the provider offices? How do we really translate that into policies, guidelines that can really turn into practice?
I can start us off with I mentioned the syphilis task force. It's one of the larger examples of the current times, but it's not the only example of syndemic work. So it's multifaceted. So if we use the syphilis example, during this just one solid year of the task force in itself, not the syphilis epidemic, but the task force itself, was able to move the needle in terms of internally, first of all, federal agencies having funding flexibilities from the Ryan White program, which is a very successful program that addresses HIV, but it's certainly not the only player out there, but they were able to have some flexibility so their recipients and subrecipients can leverage funds in a better manner, getting the Bureau of Primary Healthcare to increase awareness of it. And then on the flip side, national organizations like the American College of Obstetrics and Gynecology, they changed some of their guidelines as a result of some of this work. So it's kind of like the way I see it is it's a two-way street, right? As much as the feds need to impact policy, we also need to raise the awareness so they can inform us. Those provider groups inform us of what we need to do differently. It can't just be one way, right? So it's been a nice change in terms of that perspective. But also we know there's work to be done. We have short-lived grants that help with CHW, community health worker programs in Georgia, for example. We know how much they've been pounding the concrete to get their state to adopt it. Being at that table and having non-traditional partners, such as we've had one state representative reach out and say, what don't I know? My area is the EHE area and we're struggling with HIV things. Am I missing something? And then we need to do the reverse too, is not so much in some sort of propaganda or anything like that. It's more like, hey, just to let you all know, here's what's going on in your neck of the woods. And here's the things that we're hearing from your community in case you didn't know. typically that starts up conversations. So the CHW push in Georgia is still going on, but the neighboring state, Alabama, has put it into their state budget. So hopefully we can still be that bridge to knock down some of these dominoes. Those are just some of the examples. I have more, but I don't want to dominate the time either. Or do you
Francisco,
need?
Dylan, if you would like to add something else. If not, I have one more question. And thank you, Marcana, for the original question. For other folks, please make sure to use the chat. If you don't have the opportunity here, you can also reach out to us. And something from from the conversation when Dylan was talking, one of the things that really resonated with me was first how HIV prevention sometimes relies into fear-based campaigns, and how we know that that is not effective, how advocacy has played a role into changing really that discourse around around HIV prevention and STI prevention. So I would like to, if you could expand, Dylan, in terms of how to build, what role can providers and advocates can really play a role into building spaces that are free of stigma, that are welcoming, and that really eliminate that barrier for really to open arms for community members to make sure that you can be you. We can talk about sex. Talking about HIV is talking about sex, although sometimes that might be uncomfortable for some people, right? But those are conversations that we really must have. So Dylan, if you could expand on how ideally that would look like, and yeah, how can that improve?
Yeah, absolutely. So I'll just go back and say, like, definitely we all play a part in ending the HIV epidemic somewhere along the route. If we look at the pillars from the EHC initiative, like we all can fit somewhere in those pillars. And from a non-stigmatizing point, like stigma is going to be the ultimate killer at any point, whether that be HIV, STIs, diabetes, heart disease, whatever, you name it, because that then puts fear in people's heads and so on and so forth. So I think the easiest way that we can combat stigma from a provider standpoint is having the education. First off, like educate yourself and be sure that you know what you're talking about. And then also seeking out those extra CEUs, having information in your space about like, this is what HIV is. I remember when I first moved down here and started going to a doctor down the road, it's very interesting in Palm Beach County. There's a lot of older individuals, so it's kind of hard to find a doctor that can work with young gay people sometimes. But when I went in there, I was like, oh, okay, like, can we do an STI panel? Awesome. And then I like get them back and I was like, why didn't you put HIV in here? Like he's like, well, what are your risk factors? Like just going on and on and on, and made it very stigmatizing for me because I'm like, okay, I understand that the LGBTQ plus community is disproportionately affected, but you don't have to make it seem like I'm a statistic somewhere down the road. So yeah, just educating people and having those honest conversations. Like we're hosting an event in September called Doctors After Dark for people to have those conversations that might not be able to have it because they walk into a doctor's office and they have white room syndrome and they just completely blank, or they don't feel like their provider is culturally competent and they're literally just going in there being like, just give me my blood pressure meds, I'm good, I'll go somewhere else for testing. And just hear from the community and take feedback.
Awesome. I think those are great recommendations. And I wanted to thank everyone, all the panelists for your time, your expertise in today's conversation. as well as people, as well as the attendees. Remember that a recording of today's discussion will be added into NHMA's YouTube page and website within a week. And also, please remember that there are resources on HIV prevention and treatment, both for clinicians, patients. These are available for membership and partners, and this can be found on NHMA's Health Hub, Hispanic Health.info, as well as NHMA website and the CDC Nexus site. As you can see in the screen, there are several materials that really represent the community that they're also in Spanish, thinking about language justice. So really visit those sites and access those materials that can really support you into having this conversation with peers, with patients, with clients. Again, thank you all so much. On the chat, you can also see additional materials. So thank you all so much. We ran out of time. And again, thank you all for attending, and thank you for the panelists and NHMA for your invite to moderate this panel. Thank you all so much.